Okay, very well. Good evening, dear participants. Welcome to the open lecture and clinical case discussion on the topic of type 2 diabetes management in primary care, jointly organized by AUA, which is American University of Armenia, and Armenian American Medical Association of Boston. My name is Astrid Atanyan. I will be the moderator of today's event. Couple of technical announcements. I would like to ask all participants to mute themselves and turn on the microphone only when speaking, for example, during raising their question during the discussion. Also, in case if you are a candidate of continuous medical education credits, please be sure you're participating during the full event. And also, while participating, you indicate your full name so that we can make sure that this particular person participated in the event and we can confirm the credits. We will have a short presentation on didactics of diabetes type 1 and 2, cover their differentiation, then proceed with the presentation of quite a few clinical cases and discussions on the cases by the speakers yet. Okay, so please note that the Q&A session, meaning like we discuss the questions raised by you, will be held in the last part of the event after the presentations of didactics and clinical cases are already completed. So in case if you have questions, you are welcome to write them down in the chat, addressing your questions to everybody, not only, for example, to me or to the speakers, to everybody, so that everybody can see your questions. We already collected your questions from the registration forms, and we already made sure that at least majority of them will be already covered during the presentation, and the rest will be covered during the Q&A session. Very short information about this event and event series. This is the second event of the educational event series on various topics of local health professionals' interests, which aims at providing educational and experience exchange platform for healthcare professionals of Armenian origin living and working in the US and those living and working in Armenia. It's actually fascinating to see such a huge interest among local health community. We have an impressive number of 600, almost 600 participants. I do hope that at least vast majority will join eventually. In any case, we are going to post this event's recording on our social media platforms. Using this opportunity, I would like to also thank our colleagues from Armenian American Medical Association of Boston who made this event series possible. Okay, just for your information, dear participants, it all initially started in the form of mentorship component within one of the AUA College of Health Sciences projects, which is titled Entrepreneurs in Health, when AAMA representatives started to have monthly meetings with local health providers, healthcare providers living and working in rural communities and small towns. And later on, this idea came of making similar, though larger scale events available to the whole health community of Armenia. And here we are. So thank you. Mentors initially involved in the above mentioned projects are here today. I would like to name them and thank them. Dr. Armina Mirzabekyan, Dr. Sali Varnerian, who is also today's speaker, Dr. Anus Bogosian, and also thank you for the kind support from the president of AAMA, Dr. Hovik Chitilian, and former president, Dr. Vache Minasyan, and the board, the whole board, and the honor, of course, thanks colleagues for making this possible. By saying this, let me introduce today's speakers and give the floor to them so that I do not take much of our precious time. The first speaker is Dr. Sali Varnerian, a practicing primary care physician and a residency preceptor at Veterans Affairs Boston Healthcare System in Boston, Massachusetts. She has been a member of AAMA for many years, and she is involved in various projects of AAMA. Dr. Varnerian is a clinical assistant professor of medicine at the Boston University Chobanian and Avedisian School of Medicine and a lecturer on medicine at Harvard Medical School. And of course, Dr. Shant Parseghian, who is the chair of endocrine services for Winchester Hospital, director of Montvale Endocrine and Diabetes Center. He's also a board member of AMA, by the way, and he's a medical director of diabetes performance of Beth Israel Lehi Health Performance Network. Thank you very much, dear speakers, for being here. Floor is yours.
Thank you. Thank you, Dr. Atanyan, and everybody at the American University of Armenia Terpengian College of Health Sciences. And thank you to the Armenian American Medical Association of Boston for asking me and Dr. Parseghian to speak today. We're very happy that you have all joined us and where everyone is interested in the treatment of type 2 diabetes. So next slide, please. So the disclaimers, for me, because I work for the United States government, I just have to state that the views expressed are my views and do not reflect the official policy or position of the U.S. Department of Veterans Affairs or the United States government. Thank you. So the objectives for our presentation today are to review the indications for the newer medications in the management of type 2 diabetes, to discuss also the can you hear me well? Everything is, I got to.
Yes, we can hear you.
Okay, thank you. To discuss the use of the older glucose-lowering medications that we all are used to using, to help differentiate between type 1 and type 2, and to discuss some modern approaches to insulin therapy. So just as an overview, we're going to first have a didactic session about 30, 40 minutes about talking about pre-diabetes and type 2 diabetes, emphasizing the need for screening and diagnosis for early detection, to discuss the importance of lifestyle changes that are necessary so that we can delay and prevent the onset of type 2 diabetes. We'll have a review of the medications we use for the glycemic control of diabetes. And then we're going to have 8 short clinical cases where we discuss how to choose which medications, the benefits and their risks depending on each patient. So we all know, one slide earlier, please. We all know that type 2 diabetes is a progressive disease. We know that anyone who has pre-diabetes or diabetes, they will get worse over time. We know this. But what we can do is if they have pre-diabetes, we can treat them aggressively early with lifestyle changes and sometimes medications to try to delay the onset of diabetes as much as we can. And for those who already have diabetes, to slow down its progression. Because we know that by treating patients aggressively early on, we can slow down the progression and prevent the microvascular complications of diabetes. Now, we all know that these microvascular complications are neuropathy, both autonomic and peripheral, nephropathy, and retinopathy. And we know that our patients develop painful feet from the peripheral neuropathy. They can end up with chronic kidney disease and blindness and other visual impairments. We also know that type 2 diabetes is a major cardiovascular risk factor and major risk factor for chronic kidney disease and end-stage renal disease. So it's very important for us to find patients with pre-diabetes and diabetes to treat them early with both lifestyle changes and insulin medications so that we can slow down the onset of these complications and slow down the worsening of their diabetes. So the prevalence of type 2 diabetes, I found some data from 2021, and the Armenian data, we don't have a lot of data, but from the International Diabetes Federation, they predict that the prevalence of diabetes in Armenia is about 5.6%. However, of these 5.6%, 39, almost 40% are undiagnosed, which means they don't even know that they have type 2 diabetes. In the United States, our rates are higher, around 11% of patients who have type 2 diabetes, and about 3% of those patients are undiagnosed. According to the World Health Organization, they estimate that the rates in Armenia are actually higher than 5.6%, closer to 13 to 14%. So this, as we can tell from all the registrants, is a very important disease for us to be discussing and managing. Next slide, please.
Sorry, it's not changing.
That's okay. Thank you.
We do not see the screen, Dr. Parseghian.
I know. It stopped sharing for a second. That's why.
Okay.
So on the next slide, we're going to talk about screening and who should we screen. So I can start talking before the slide. Screening and evaluation must be done by the primary care provider, physician, nurse practitioner, or physician's assistant. We are the patients that see the patient first. Here it is. So the criteria for screening, the American Diabetes Association every year puts out an update about management of diabetes. And over the last few years, things have changed a little bit, but not too much. The most important change is that at age 35 is when we should start screening all adults for diabetes, no matter what. It used to be 45, now it's 35 years old. Then in addition to that, any adult under the age of 35 or over the age of 35, if they are overweight or obese with a BMI of over 25 or 23 in patients of Asian ancestry, they should be screened. If they have a first-degree relative with diabetes, or their mother, brother, father, sister have diabetes, they need to be checked for diabetes. If they have a history of cardiovascular disease, if they have a history of hypertension, if they have a history of atherogenic dyslipidemia, where they have a low HDL, high triglyceride, and moderate LDL level, those patients need to be screened for type 2 diabetes, because these are the patients that are more likely to have metabolic dysfunction associated complications with the obesity and the steatotic liver disease. And those patients also need to be screened. Women with polycystic ovarian syndrome need to be screened. And then women with gestational diabetes during pregnancy should be tested every 1 to 3 years. And then the one physical inactivity. So how many of our patients have this issue of physical inactivity? So basically, quite a few of our patients need to be screened for diabetes. And if the results are normal, if they don't have any of these risk factors, you can check at least every 3 years. But if they have any of these risk factors, you should be checking more often. And then also patients who are on HIV medications or have poor oral health, or have a history of pancreatitis. These are also patients that need to be screened for diabetes. So as you can see, there are quite a few patients in our panel that need to be screened for type 2 diabetes and pre-diabetes. Next slide, please. So how do we screen? As we know, we need two values. We need two values, can be two different values from the same blood sample or from different blood samples. We usually use the fasting plasma glucose and the hemoglobin A1C to screen for diabetes. If they have symptoms of hyperglycemia, and which are polyuria, polydipsia, and blurry vision, and their glucose levels are over 11.1 millimoles per liter or over 200 milligrams per deciliter in the United States, these patients are assumed to have diabetes, and oftentimes you will get an A1C and it will be above the level of 48 millimoles per mole that diagnoses diabetes. We know that fasting plasma glucose levels of less than 5.6 millimoles per liter or less than 100 milligrams per deciliter is normal, but anything between 5.6 and 6.9 is considered pre-diabetes. Same with the A1C. Any A1C level between 39 and 47 millimoles per mole, or 5.7 or 6.4% in the United States, makes the diagnosis of pre-diabetes. So, and the two results must be concordant. So if one value, if the fasting plasma glucose is 7 millimoles per liter, but their A1C is 39, then they're considered pre-diabetes. But it's still important to find these patients in the pre-diabetes or diabetic state, because we need to aggressively treat them. Next slide, please. So before we get to more, I want to say just a little bit about the pathophysiology of diabetes. It is very important for us to find patients in the pre-diabetic state before they become diabetic. As you can see, when a patient takes in a glucose load, when they eat or drink something, and the glucose starts to get into the bloodstream, your glucose levels start to rise. But in patients who don't have diabetes, your body is ready. The insulin, you have preformed insulin ready to get that glucose out of the bloodstream. However, in the pre-diabetic state, when patients have a fasting blood glucose of only 6.4 millimoles per liter, they have lost that preformed insulin ability. They do not have insulin ready to go. So as the glucose is entering the bloodstream, there is no insulin to take care of it. So the pancreas has to start making insulin. So already this is the part of the vicious cycle that is prediabetes and diabetes. We've already lost the ability to take care of hyperglycemia quickly. So as the level goes up, the blood glucose level will go up, and there isn't enough insulin to take care of it. And that's in the pre-diabetic state. Once they reach a fasting blood glucose of 7 millimoles per liter, so at the diagnosis of diabetes, they've already lost, as you can see in the orange line, 50% of their beta cell function. So not only do we not have that preformed insulin to take care of the hyperglycemia, as the pancreas is making insulin, it's only making 50% of what is necessary. By the time they're frankly in diabetes, they've lost already 75% of beta cell function. So it's very important for us to find patients in the pre-diabetic state when they've already lost that preformed insulin spike, or they've already before they've lost beta cell function, so that we can try to prevent the progression into diabetes. Because in the pre-diabetic state, as you can see on the bottom, they already have microvascular complications of diabetes and can develop macrovascular complications also. Next slide, please. So this is the vicious cycle that is type 2 diabetes. You develop hyperglycemia. You don't have the preformed insulin spike. The increased glucose level in the blood increases the insulin resistance in the periphery. When you have increased insulin resistance, you have decreased insulin secretion. When you have decreased insulin secretion, because insulin is important to stop hepatic gluconeogenesis, you have decreased glucose uptake in the cells, more hyperglycemia, and then the liver starts making glucose. You have more gluconeogenesis, and then that leads to more hyperglycemia and more insulin resistance. So this is the vicious cycle that is type 2 diabetes. So we need to stop it early in the pre-diabetic state before this cycle gets going. Next slide, please. So why do we need to screen and treat prediabetes and diabetes? We need to identify these patients early so that we can modify their risk factors, treat them so that we can prevent and delay and slow down the progression of type 2 diabetes. We can preserve their beta cell function, and we can prevent the microvascular complications of neuropathy, nephropathy, and retinopathy that occur early. How can we do this? Lifestyle changes are the most important thing. It is the most challenging thing for us to do, but is the most important thing. No matter what medications we give them, unless they modify their lifestyle with diet, exercise, and weight loss, we cannot help them the best way. So because patients in the pre-diabetic state have lost that preformed insulin spike, our goal is to slow down the entry of glucose into the bloodstream so that the pancreas has time to synthesize insulin and secrete insulin to take care of the glucose load. So these are foods that have a low glycemic index. Foods that have more fiber and more protein slow down the digestion of the starch in our diet so that we slow down that entry of glucose. This is the healthy plate that the United States government has put out, emphasizing that grain should be a quarter of your plate. The bread is there, it's not on the side. Your rice, your pasta, your buckwheat, your potatoes, that's in that 1/4 of your plate should be that. The rest should be fiber from salads and fruits and vegetables, and protein from meat or fish or chicken or beans or lentils. So this is the whole point of this is they need to work on their diet to decrease insulin resistance. Next slide, please. And then we all know that there are many studies have shown that exercise and weight loss are imperative in helping to reduce the risk of developing type 2 diabetes. One series of studies is the United Kingdom Prospective Diabetes Study back in 1998 until now has shown that lifestyle interventions, including exercise, can reduce the risk of developing type 2 diabetes. We know that exercise increases the number of insulin receptors and the affinity of those receptors to insulin so that the insulin binds better and can help decrease insulin resistance and help decrease gluconeogenesis. There was a study in 2007 in the Annals of Internal Medicine where they took patients, they gave them a physical trainer, they did exercise, aerobic and anaerobic, for 45 minutes, 3 times a week for 6 months. And by doing that, only that, they lower their hemoglobin A1C by 1 percentage point, by approximately 3 millimoles per mole. So just think, if we can do that with just lifestyle change without any medication, that's as much as some medications can do. We also know that moderate exercise, 30 minutes, 5 days a week, or just 2.5 hours a week, along with a healthy diet and weight loss of a goal 7% or between 5 to 10%. We know in the diabetes prevention program, this lowered the risk of progression to diabetes by 58%. And this is without medication. So this is why it's so important to emphasize lifestyle changes in our patients. Once you have the diagnosis of diabetes or prediabetes, you have to think about what your goal hemoglobin A1C is for these patients. On the left, you can see if patients are young and healthy, they haven't had diabetes for a long time, they don't have other complications, they're not on a lot of medication, we want to get their A1C down as low as we can get it, below 6.5% or 48 millimoles per mole. Why? Because we want to slow down the progression. We want to delay the onset so we can prevent them from developing the microvascular complications of diabetes. And we can try to hold them in the pre-diabetic or even better state before they progress. However, on the other side of the spectrum, on the right, when patients are old and sick and near the end of life, they have multiple medical problems, there are multiple medications, you have to think about their quality of life. You have to think about their risk for hypoglycemia. You have to think about being too aggressive and letting not being too aggressive and letting their sugars run higher, their glucose levels run higher, usually 64 millimoles per mole or a little higher. So most patients, however, are in the middle. Most healthy adults, we want their A1C to be at least less than 53 millimoles per mole or 7%. Go next slide, please. So this just shows that this is where we want most of our patients to be at healthy adults, less than 53 millimoles per mole. And this corresponds to a fasting blood sugar of between 4.4 and 7.2 millimoles per liter, or 80 to 130 milligrams per deciliter. And we want their glucose levels after a meal, 1 to 2 hours after a meal, to be less than 10 millimoles per liter or 180 milligrams per deciliter. And again, this is for patients we want an A1C less than 7 or less than 53 millimoles per mole. So the newest recommendation since the latest 2022 guidelines, as we said first, that we start screening everybody at the age of 35, not 45, no matter what their other conditions are, every adult. But the biggest change has been that we are now using and are encouraged to use certain medications to reduce the risk for cardiovascular disease and kidney disease in certain patients. And these are the patients who already have atherosclerotic cardiovascular disease. Atherosclerotic cardiovascular disease includes those who already had a heart attack or have angina, have coronary artery disease, already have or transient ischemic attack. If they have carotid artery stenosis or other peripheral arterial disease, including intermittent claudication and aneurysms in the abdomen and the thorax. So these patients who already have atherosclerotic cardiovascular disease, who already have heart failure, whether it's heart failure with preserved ejection fraction or reduced, or already have chronic kidney disease, we need to use the certain medications such as the SGLT2 inhibitors and the GLP-1 receptor agonists that have been proven to reduce cardiovascular and kidney and chronic kidney disease risk. We also want to use these medications in patients who are at high risk for atherosclerotic cardiovascular disease. These are patients who are 55 years old and over and have 2 or more additional risk factors, such as
Vidi atherosclerotic Ein bujarunare of kerunen girution, zahomen, hypertonia, and zachporokain hypertrophia.
High triglycerides and moderate or high LDLs. They already have albuminuria, they already have protein in their urine, and they have retinopathy. So all these are, okay, next slide. And we use these medications in patients who don't even have diabetes. So this is the algorithm. I know it's a very busy slide, but I just want to emphasize that on the left, you see that patients with diabetes who already have atherosclerotic cardiovascular disease, they're at high risk for cardiovascular disease. They have heart failure, whether preserved or reduced ejection fraction heart failure, and they have chronic kidney disease. And chronic kidney disease is defined as a GFR of less than 60 or already have albuminuria of greater than or equal to 3 milligrams per millimole or 30 milligrams per gram. So it's a very light diagnosis. So these patients, we should first use the SGLT2 inhibitors or GLP-1 receptor agonists that have been approved for these cardioprotective and kidney risk reduction. And then everyone else falls into the other category. This is just a bigger version of the same slide. So glucagon-like peptide 1. These are the medications that the GLP-1 receptor agonists are trying to mimic this hormone that we naturally make. So this is a hormone. GLP-1 is a hormone that we naturally make, but they found that diabetic patients either make less of it or are less responsive to it than non-diabetic patients. So GLP-1 is secreted in response to a meal. They're not secreted when we don't eat, but when we eat, they start being secreted. And basically what they do is they tell us to stop eating. They say, you're full, you can stop eating. They delay gastric emptying. They decrease your appetite, the effect on your brain. They increase insulin. They decrease glucagon secretion, so we don't have hepatic gluconeogenesis. And then these GLP-1 hormones are deactivated by the DPP4 enzyme, which we'll talk about later. So next slide. So GLP-1 receptor agonists, the ones that have been proven to significantly reduce major cardiovascular events in patients with ASCVD or high risk for ASCVD and decrease albuminuria in patients with chronic kidney disease are these three: semaglutide, dulaglutide, and liraglutide. These do not cause hypoglycemia because they're only secreted in response to a meal. They all promote weight loss, as you I'm sure have heard. You can use them in combination with other medications, including insulin, and they're very effective. They lower the A1C by an average of 11 millimoles per mole or 1 percentage point, but sometimes it's more. You have to be careful, though, of the side effects. If anyone has a history of pancreatitis, you cannot use it because it can increase the risk for developing pancreatitis. If patients already have gastroparesis, as an autonomic neuropathy complication of diabetes, their system is already slow, giving this is only going to worsen their symptoms and cause abdominal pain. If they have a family history of thyroid cancer or MEN2 syndrome, then also it's contraindicated in these patients. Some of the side effects of nausea, vomiting, and diarrhea can be ameliorated with lower doses or slowly titrating the doses. These are expensive medications. Most of them are injectable, and they're not approved for type 1 diabetes. So these are something to remember about the GLP-1 receptor agonist. Along with GLP-1, another hormone that is secreted in response to a meal is called the glucose-dependent insulotropic polypeptide. It used to be called the gastric inhibitory peptide. This works similarly to GLP-1, except it doesn't affect gastric motility. It increases glucose-induced insulin secretion. Again, it only works when patients are eating, and it enhances glucagon activity when patients are hypoglycemic. So tirzepatide is the one medication that is a dual-acting GLP-1 and GIP receptor agonist. This combination has not been proven to reduce any cardiovascular or chronic kidney disease risk, so it's not recommended in those patients yet. The next category are the SGLT2 inhibitors. These are the sodium glucose cotransporter 2 inhibitor medications. Basically, what these do is they block reabsorption of glucose in the proximal tubule. So patients with diabetes end up urinating out the glucose. Now, you have to remember, though, if their GFR is less than 45, it's not going to help as much with their glucose lowering because you need a GFR over 45 to block this reabsorption. However, they are helpful in other situations other than just lowering diabetes. However, when you use them and the GFR is over 45, you can lower the hemoglobin A1C by 5 to 8 millimoles per mole on average, 0.5 to 0.7 percentage points. These also are helpful in lowering blood pressure, and they reduce proteinuria. And the ones that we have been proven to reduce not only lower glucose levels, but they also reduce cardiovascular events in patients with already have cardiovascular disease. They reduce cardiac mortality and hospitalizations with patients with heart failure, and they reduce major cardiovascular events in patients who are at high risk for atherosclerotic cardiovascular disease if they don't already have it. and it reduces their risk of progression of chronic kidney disease and albuminuria. Their GFRs get worse more slowly with these three, the dapagliflozin, canagliflozin, and empagliflozin. These three have been proven to do so. With the side effects, however, are something we need to think about. You don't want to use them in patients who have insulin deficiency, like type 1, or patients who have pancreatic insufficiency and don't make enough insulin. And because the way they work is to increase the glucose in the urine, this increases urination and can cause low blood pressure, orthostatic hypotension, acute kidney injury, volume depletion, but it can also cause more urinary tract infections, genital yeast infections, and necrotizing fasciitis. So these are things you have to be thinking about before you give this medication to your patients. You also need to watch carefully for foot ulcers. They are expensive also. So this is just a table just to help summarize. Basically, on the bottom, the SGLT2 inhibitors, especially canagliflozin, dapagliflozin, and empagliflozin, are approved for patients who have all these conditions, whether or not they have diabetes. So patients who have atherosclerotic cardiovascular disease or at high risk for atherosclerotic cardiovascular disease. In patients with diabetes, we have decrease in the major adverse cardiac events. In patients with heart failure, whether it's reduced ejection fraction or preserved ejection fraction, we reduce their risk for cardiovascular death and hospitalization. And in patients with chronic kidney disease, we reduce not only albuminuria, but also progression of their chronic kidney disease with these three. For the GLP-1 receptor agonists, they have not been shown to be helpful in patients with heart failure. However, they have been shown to be helpful in reducing the risk for atherosclerotic cardiovascular disease in patients with those conditions or at high risk for those conditions. And in chronic kidney disease, these three have been shown to decrease albuminuria. And most recently, semaglutide has been shown to also decrease progression of CKD. That is the newest information. Next slide. So the one other class of new medications that we wanted to mention today were the DPP-4 inhibitors. The DPP-4 inhibitors inhibit the enzyme that causes the breakdown of the GLP-1 that your body naturally makes. These are oral medications. You don't gain weight or lose weight. They don't cause hypoglycemia because, again, they're just enhancing the ability of GLP-1 to last longer, the one that they're already making, and GLP-1 is only made in response to a meal. They lower the A1C about 0.5 to 0.8 percentage points or 5 to 9 millimoles per mole, so it's not a big drop, but it's something. You don't use them with the GLP-1 receptor agonist because they're sort of doing a similar thing, and you want to adjust the dose for renal function for some of them. The side effects are different. Yes, there is a risk for pancreatitis also with these medications, though it's less than with GLP-1 receptor agonists. And it might increase the risk for heart failure. So if patients are in heart failure that's not controlled, we wouldn't recommend it. But if their heart failure is controlled, you can try it. And then they have these funny urticaria with hives and angioedema and upper respiratory symptoms are the side effects. So just one to mention also about the older glucose-lowering medications that we all know and use and are used to using. Metformin is still the first choice for many of my patients and yours. Metformin is great at breaking the vicious cycle that is type 2 diabetes. It increases insulin sensitivity in the liver so as to decrease hepatic gluconeogenesis, which is so important. We remember that metformin also in the UK PDS studies, in the United Kingdom studies, did show that if patients were obese, they lost about 4.5 kilograms the first year they were on it. So it helps with weight loss, not as much as some other medications, but it does help. We want to make sure that if their GFR is less than 30, once their GFR is 30, we must stop it. Once their GFR is less than 45, we must cut the dose by 50%. We need to monitor their vitamin B12 levels because metformin does decrease absorption of B12 in the ileum. So after they've been on it for a year or two, you should monitor their vitamin B12 levels. Remember, it needs insulin to act, but it can be your own insulin or it can be insulin that patients are injecting. And the nice thing about this is that you know that insulin promotes weight gain. Well, if you keep metformin as long as you can until the GFR is hits 30, then you can use less insulin and you have less weight gain with the insulin. So this is also important to remember. We know that the adverse effects can be diarrhea or nausea, but that's why we increase the dose slowly. We start at 500, wait a few weeks, go to 1,000, then 1,500, and monitor for diarrhea. If they get diarrhea at 1,500, but they're okay at 1,000, go back to 1,000, wait a few weeks, and then try 1,500 again. So sulfonylureas, as you know, are also very effective. They also lower the A1C by 22 millimoles per mole, 2 percentage points. So, and that's additive with metformin and other medications. But the biggest risk with the sulfonylureas is the risk for hypoglycemia, similar to insulin. And of course, pioglitazone, which I don't use very much anymore, but it has its place for patients who need it. It lowers the A1C somewhere between 5 and 16 millimoles per mole. The adverse effects are what limit the use of pioglitazone. It increases plasma volume, so it increases the risk for peripheral edema, for heart failure, especially in patients who are also on insulin, and weight gain. It's banned in use in France and Germany because of the risk for bladder cancer and fractures. This is controversial, but if someone has bladder cancer or risk for bladder cancer, we don't want to use it. And we want to avoid it if they have active liver disease other than steatosis of the liver, for which they have been found to be somewhat helpful. The nice thing about pioglitazone is if they have chronic kidney disease, you can still use it. So with all these medications, including insulin, next slide, how do we choose which one to use? We don't have to go through this slide, it's too much, it's just there for reference. So the key things we all know already, and this is what we do, we know our patients well. That's what our job is as a primary care provider. We have to know our patients well. We have to understand their lifestyle, their work schedule, their diet. We have to understand what they're willing to do and what they're not willing to do. We have to think about what is their goal A1C? Where do we want this patient's A1C to be? We have to think about how long they've had diabetes. If they've had it for only a short time and they're young and healthy, we want to really be aggressive and get those numbers down. If they're older and sicker, we might be a little more lenient. We have to make sure, we have to know their renal and hepatic functions so we know which medications to give and how to adjust the dose. And we have to think about their comorbidities. Remember, if they have atherosclerotic cardiovascular disease or they're at high risk for atherosclerotic cardiovascular disease, then we preferentially want to use the GLP-1 receptor agonist or the SGLT2 inhibitors that have been proven to have cardiovascular benefits. For patients with chronic kidney disease, again, we want to make sure we use the SGLT2 inhibitors or GLP-1 receptor agonists that have been proven to reduce the risk of progression of chronic kidney disease and albuminuria. For patients with obesity, the GLP-1 receptor agonists and the GLP-GIP receptor agonists are most effective at weight loss. And for heart failure, the SGLT2 inhibitors are your first choice in patients with diabetes. We have to think about medication interactions. Think about what other medications they're on that might interact with these medications. We have to think about their adverse effects of these medications. For example, if someone has urinary incontinence, the SGLT2 inhibitor that's going to make them urinate more might not be the right medicine for them. Think about the risk for hypoglycemia. Do they have symptoms of hypoglycemia, or do they have the autonomic neuropathy of diabetes that causes hypoglycemia unawareness, so they don't feel the symptoms? Or do they have symptoms of hypoglycemia and they don't know what to do with it because of cognitive deficiencies? You have to think, are they willing to do an injection? The GLP-1 receptor agonists are once-a-week injections. Some people might like it, some people might not, or do they want oral? And then you also have to be aware of the cost. If they can't pay for something, they're not going to take it. So that's not helping you or them. You have to think about what they prefer, what's available to them. Some medications might not be available, and what's going to be the medicine that they're most likely to be adherent to. And you need to know when to refer to an endocrinologist. Next slide. So most cases of diabetes, we can usually manage as a primary care provider and your associated staff, the dietitian, the pharmacist, the nurse. But when would you refer an adult patient with diabetes to an endocrinologist? So these are a few of the time. Of course, at any time, if you feel uncomfortable, you should refer to an endocrinologist. But these patients in particular, so patients with type 1 diabetes or diabetics with pancreatic insulin deficiency due to whatever reason, those patients really need to be seen by the endocrinologist and managed. Refer to the endocrinologist when the classification is not clear, if you're not sure if they have type 1, type 2, or one of the other types. If the woman wants to be pregnant before they become pregnant, or if they're already pregnant, those patients really need to be followed closely by an endocrinologist. if they already have multiple severe complications of diabetes, such as foot ulcers, neuropathy, chronic kidney disease, or cardiovascular disease, those patients need to be seen by the endocrinologist. If they're difficult to control, you're using 2 or more medications and you can't control them, or their glucose runs from very high to very low, those patients need to be seen by the endocrinologist. And if they're on many other medications, such as chemotherapy or chronic corticosteroids, their management might be more better to be help. The endocrinologist can help you with that, or they're in the hospital a lot because of diabetes or not taking their medications. So now we will transition into discussion of the cases, and Dr. Parserian our endocrinologist, will help us through the reasoning of which medicine to choose and why. So I will present the cases, and Dr. Parserian will do the discussions, and hopefully this will help all of you. So the first case is a 40-year-old male with a history of obesity, obstructive sleep apnea, and hypertension. His father has type 2 diabetes. His BMI is 36. His blood pressure is high. And his A1C is 42 millimoles per mole, or 6%, which is in the pre-diabetic range. His liver function, kidney function is normal. He doesn't have proteinuria. He has high LDL, 4.5 millimoles per liter. He has high triglycerides at 285 3.2 millimoles per liter, or 285 milligrams per deciliter, and his HDL is low at 0.7 millimoles per liter. So what do we do next?
Okay, I'll take it from you. Thank you, Sally, for the presentation. I'm just going to make a couple comments, during the presentation, from a specialist point of view, when we're going over the cases. So the cases will take you from the beginning of diabetes toward very complicated end life, patient. So you'll learn how to progress your thinking and your management. So this patient is a 40 years old. He has no history of diabetes, if you notice on the top. So he has risk factors: obese, sleep apnea, hypertension, meaning you have to think about cardiovascular complications. So the first thing you do, you check the A1C because you have a high risk patient. It's 6%. So that is only one reading. So what is your classification for this patient? Is this patient diabetic, pre-diabetic, impaired fasting glucose, or glucose intolerance? So you have to know first how to address the patient. You should not label someone with diabetes based on one abnormal hemoglobin A1C. So the first thing you need to do is definitely confirming hyperglycemia. So you have to do another blood test beside the A1C or the random glucose or the fasting glucose to make sure this patient has truly hyperglycemia. Does it have pre-diabetes, or that A1C was a mistake from the lab or something like that? So the first thing, always confirm hyperglycemia before you call the patient he's diabetic or she's diabetic. So look at the A1C, look at the data you have, number one. Number two, anytime, as we said in the beginning, when you have a pre-diabetes or diabetic patient, the first thing you need to work always on lifestyle modification. Lifestyle modification includes two things: exercising at least 2.5 hours a week, which includes 50% cardio and 50% resistance. So it's very important to build the muscle mass, because when you depend on calorie deficit diet only, meaning you tell the patient to stop eating and they really change their diet, they end up eating 1/3 of their food, they will lose 20, 30 pounds or 10, 15 kilograms, but at the same time, they will lose muscle mass. So that's not what you want in your patient. You want your patient to build muscle to be able to metabolize glucose better and to be more sensitive to insulin. So that's why exercising is very important. And the second thing, which is in the lifestyle modification, is the dietary modification or change in the diet. Meaning what? Patients should learn how to eat better. So cutting food is not always the answer. You should not tell the patient, that you like certain food. I mean, I'm not sure how it's done, okay, one of my favorite restaurants, you go to Mertau over there and have, lahmacun or baniri börek every night, for example. That's his favorite meal to the patient. You cannot tell him you cannot have those favorite meals that you grew up on forever. You have to have salad only for dinner. So you have to know how to direct the patient, how to educate the patient about the food content. So when they eat their favorite food, which caused the problem to start with, they don't fear the food and they eat enough to enjoy the experience, enjoy the food, but not to cause more weight gain and more insulin resistance and more damage. So eating right, always the key. And again, that not necessarily eating less. Sometimes we have to change the food content. Sometimes you have to change the food timing. For example, people, they work, for long hours, they may have one large meal at night. If you teach them how to divide the meal over 3 parts, breakfast, lunch, and dinner, they may end up eating less food and be less hungry, and that will give them better metabolic profile. So keep in mind one thing: changing diet is not always eating less. It is always eating better. So after you confirm the glucose, you talk to them about lifestyle modification. You have to look at the other risk factors. So this patient has a sleep apnea and obesity, and most likely in hypertension. Most likely in a couple of years, you will develop diabetes, low testosterone, hypogonadism. So all this coming from one problem, which is called obesity. So obesity will cause all these complications. So you need to target obesity more than anything else besides the glucose, because by targeting obesity, you will reduce the risk of progressing to diabetes, you will improve the sleep apnea, you will improve the hypertension, and most likely his cholesterol level will get better. But if that's not enough, you always have to think a step ahead. So Sally said, that you develop microvascular complications, or even like macrovascular complication very early stage in your life, when you have these risk factors. So you have to look at the cholesterol, you have to look at the blood pressure. You should not be shy to tell the patient, I have to treat your blood pressure, so that will not cause further problem in the future to give you macrovascular complications. Or the same thing with statin. They come and tell you, my cholesterol is perfect. You tell them, yes, your cholesterol is perfect, but you are not perfect because you have high glucose. So anything perfect in the setting of hyperglycemia is not perfect anymore. So for example, your LDL is 100. You're not diabetic, that's great. Your LDL is 100. You're diabetic, that's bad. So you have to always think about the patient as a different unit when they have the glucose balance problem. So always think about the other comorbidities that will affect the future of this patient when he becomes diabetic, and try to treat from day one. So again, it's very common to use metformin for weight loss, or GLP, for weight loss. So metformin doesn't give you much weight loss, maybe like 2 or 3 kilograms, I would say at the most.
In progress.
But GLP-1 receptor agonists that they have indication for weight loss, they can be used for a patient like this. Because again, think about the main problem. When you look at the slide, you should see only one word in this biggest slide. It's called obesity. You target obesity, you target 5 other problems with it. But you target sleep apnea, you're just targeting one problem out of the many problems. You can save the patient by just targeting the obesity. So look at the most important finding in the patient, and just try to target that big problem that will help you to fix automatically 3-4 other problems. So confirm hyperglycemia, lifestyle modification, other risk factors, and think about changing the patient future. Okay, Sally, next case, please.
Okay, so the next case is a 45-year-old female with a history of, again, obesity. She has a family history of heart disease and type 2 diabetes. So for her BMI is 32. Her blood pressure also is high. Her hemoglobin A1C is 5.2 millimoles per mole, or 6.9%. And her albumin creatinine ratio is 3 milligrams per millimole. So her LDL is high at 3.7 millimoles per liter at 143 milligrams per deciliter. Her HDL is low, and her triglycerides are high. So what will you do for this case?
Thank you, Sally. So there's some change in the slide here. This patient has existing diabetes, by the way. So it's not only obesity. So otherwise it will be the same patient as the first patient. So this patient has diabetes and has obesity, plus family history of CAD and diabetes, BMI 32, A1C confirmed more than once to be in the hyperglycemia range, and the cholesterol is elevated as well. So again, now we have a diabetic. You're past the first stage. Again, lifestyle modification. The first medication to start for any patient with BMI of 32 or an obesity with diabetes is metformin. You start with the low dose and you go all the way up to 2,000 milligrams. So the lowest approved dose of metformin is 500. The highest approved dose of metformin is 2,500. But you get the most benefit at 2,000. So never push the metformin more than 2,000 milligram daily, because you don't get any more benefit, but definitely you get the side effect of metformin, which is mainly GI in most patients. One thing about metformin, you have to realize that it's a very cheap drug. It's been around since I believe in the late 70s, and it comes from different part of the world, and maybe the biggest exporter of metformin is India. So you can develop side effect to metformin anytime when you're treated with the medication. So it doesn't matter, patient on metformin for 10 years, they call you with the diarrhea or a heartburn or stomach ache. So that can be metformin still. So never exclude or say, oh, the patient took metformin for 10 years. Now there's no point of changing the dose and ordering, scopes up and down and costing the patient lots of money. The reason why you may get metformin anytime, because sometimes the supplier will change the manufacturer. And if the metformin molecule or the drug is not made with a clear metformin ingredients, that is when you may experience a GI side effects. So it's very common for patient to be on the drug, buy it from different manufacturer, and get the side effects. At that time, like Sally said, you can always cut back the dose and give them the highest tolerable dose. So if they cannot do 2,000, do 15, not 15, do 1,000, and go down from there and add another agent if you have to. So that's number one. Number two, after, again, lifestyle metformin, the blood pressure. This patient's blood pressure is not controlled. Per ADA guidelines, per ADA guidelines, the blood pressure should be under 130 over 75 in the office checking. So you should add blood pressure medication. And the first agent to add to any diabetic is ACE inhibitors, unless they're in pregnancy age or they're trying to get pregnant or they have contraindication for the drug. You have to be careful at that time. But the first medication to add for any diabetic who has hypertension or microalbuminuria is ACE inhibitor. And then you can add second, third agent, calcium channel blocker, hydrochlorothiazide, beta blocker, whatever you feel appropriate. But one point over here is very common. You see that primary care, especially, they may prescribe ACE inhibitor for patients that they have no high blood pressure, no hypertension, and no microalbuminuria to prevent future diabetic kidney damage. That is not the right practice. You should not start ACE inhibitor on any diabetic unless they have hypertension or existing diabetic nephropathy. Otherwise, ACE inhibitor is not needed, please. The third or the fourth factor that you have to look for is, the patient LDL. This patient LDL, again, is 143, which is elevated. HDL is 32 low, triglyceride 185. So the first thing for cholesterol, regardless what you do, is diet, eating better, exercising to bring the HDL up, lower the fat content, and fried food to lower the LDL and the triglyceride. But any diabetic past age of 40, type 2, I'm talking about type 2 here, not type 1. Any type 2 diabetic past age of 40, regardless of their LDL, they should be on a statin. And you can prove that to the patient by calculating their cardiac risk. And once you put diabetes past age of 40, the risk to develop coronary artery disease will be high enough to indicate statin therapy. So that most of the time, people, they refuse or they resist the idea of going to statin because they believe their cholesterol is very good. So your job is to educate them as much as possible to have them on statin from day one, because the sooner you treat the diabetes, the risk factors, including, the blood pressure, cholesterol, the lifestyle, the better you prevent them from having their complication in the future. So from day one, you have to treat them from day one as soon as possible, please. Next slide, please. Oh,
The
so
follow-up in this case, she presented 3 months later. Now her A1C is 58 millimoles per mole, or 7.5%, up from 52. And her BMI is 32, and she's on metformin 2,000 milligrams a day already. So what would you consider next?
Thank you. So again, this patient, A1C, you put them on metformin, and the A1C still came up to 7.5. Patient is obese. If you remember, the BMI is 30, HTC BMI is 32 in the obesity range. So what's the next agent to add after metformin? This patient has no, if you remember, like Ivan in the beginning said, that you have to add specific agent for specific benefit when it comes to renal or cardiovascular. So this patient has no other risk factors, meaning you can add one of these few agents. So the first one is SGLT2 inhibitors. So they're great drugs. They're expensive. One thing, the genital yeast infection, you have to worry about, especially more for ladies than men. But men, if they're not circumcised, they have very high risk to have genital yeast infection. So if you're prescribing it to a man patient and the patient is not circumcised, please be careful, because most likely that patient will have genital yeast infection. And that male patient, if he's having already genital yeast infections a couple times a year, 3-4 times a year, please do not prescribe SGLT2 inhibitor, because that's going to get worse, and then you will have the risk of Fournier gangrene. That's going to be a problem. So know your patient very well. The second choice that you can add is a GLP-1 receptor agonist, and that is a great choice for this patient because the patient is obese, 32 BMI, so will benefit from some weight loss. And remember, weight loss will help everything. There's no bad result of losing weight. You're losing weight always help the patient. You always get the benefit on different levels. So the first two agents are expensive. Oh, I will go back to the GLP-1 agonist. So you heard earlier that if you have pancreatitis, you cannot use the medication. Actually, if you have unexplained pancreatitis, so if the patient had pancreatitis from gallstone, from hypertriglyceridemia, from alcohol, and you can explain why the patient had pancreatitis, you can use GLP-1 receptor agonist. So it's not like one-time pancreatitis and that's it, you cannot use the drug. If you have a reasoning, first, you have to make sure the patient had truly pancreatitis. That's very misdiagnosed, and patients, they like to use the word, they can, because they feel like it's more prominent word. But make sure the patient had pancreatitis first. Second, look for a reason, and if you find a reason, you still can use GLP-1 for those patients, please. Okay, so the first two agents are expensive. I know they're available in Armenia, but I don't think they're very accessible. So sulfonylurea, they're good drugs. They're old drugs. They work perfectly fine. But hypoglycemia is concerned with the patient. So you just have to make sure the patient takes the sulfonylurea before their first meal and before the last meal. It's very common practice in the US that, we write BID on the prescription, say twice a day without any clear direction to the patient. So when the patient takes the sulfonylurea before bedtime, that will cause hypoglycemia after midnight, definitely. So you have to be very careful to educate the patient first about what is low sugar. So patient, they should know how to detect low sugar. Then patient should be educated how to manage low blood sugar, and then how to prevent low blood sugar. So if you educate the patient about these three factors, detect, treatment, prevention, most likely the patient will not have hypoglycemia. And at least if they have a hypoglycemia, they will call you back saying, I had low sugar, let's do something. So you have to be on top of hypoglycemia when it's caused by any diabetic agent, but especially sulfonylurea. And the first thing is to find a reason, to find explanation for the low sugar. Let's say, patient took the glipizide in the morning and they went to the church mass, they forgot to eat breakfast, forgot to eat lunch, they had the low sugar at the church, they collapsed. So you tell the patient next time, if you're going to the church, make sure you eat your breakfast. Or if you're not sure you're going to have your breakfast or your lunch, don't take your pill that morning. So teach them how to avoid hypoglycemia. The fourth agent, which is pioglitazone, again, it is available in Armenia. The class is one of the smartest classes out there for medication who came out to the market in the early 1990s. But the problem is, the cardiac function or heart failure with the class in general. So, and the second issue is the weight gain. So you have to be first careful the patient, you're not prescribing to pioglitazone to a patient who does not have good heart function, meaning like, ejection fraction is low. And definitely you cannot prescribe it in a patient for a patient who is an active heart failure. So let's say you have a patient come to the hospital with MI, ejection fraction is 25%, hyperglycemia. Please do not prescribe pioglitazone for those patients. But you have to watch for the weight gain. So pio comes usually with 3 doses, 15, 30, and 45. In my practice, I hardly ever use the 45, but the 30 and the 15, I use them significantly for different reasons. First, if you have a patient with metabolic profile, meaning, they have, excessive body fat or abdominal fat, and if you look at their arms and their legs, you can see their veins. So pretty much, it's like a balloon-shaped body with the arms and the legs extending you can see the muscle lines and the vessel. That person has severe insulin resistance. So targeting insulin resistance by losing weight, using metformin, using GLP-1 receptor agonist, or pioglitazone will help you a lot. So remember, patient who has severe insulin resistance, abdominal fat, they have morning hyperglycemia, pio will be a great choice for them. But if you have a thin patient, no abdominal fat, giving them pio may not give you the benefit you're looking for. So that's number 2 factor. Number 3, pioglitazone has proven cardiac benefit and proven stroke prevention benefits. So if you have a patient who in their 60s, they already had a stroke, and you would like to give them some diabetic agent to prevent a second stroke, and in this case will be semaglutide, which has, the benefit of reducing the recurrence of cerebrovascular accident, and it's expensive, not affordable. Pio, with good normal heart function, will give you some prevention from stroke. So remember that. The same thing for a patient who has CAD, but with normal ejection fraction, pio will give them cardiac benefits. So do not exclude these 2 agents, sulfonylurea and pioglitazone. Even in the US, we use them a lot, by the way. The last choice is insulin. Insulin can be used anytime for any patient, especially, if you cannot afford SGLT2, you cannot buy GLP, patients having significant hypoglycemia or sulfonylurea, or their diet is very irregular, they have a low ejection fraction, so pretty much you have no choice but using insulin. So insulin can be always used for any patient, but again, for this patient, we rather use something to help them to lose weight, since insulin may tend to make the patient gain a few pounds. Next case, Sally.
Okay. So the third case is of a 65-year-old male with type 2 diabetes, hypertension, hyperlipidemia, coronary artery disease status post-CABG, bypass surgery, and a normal ejection fraction. He is already on metformin, the maximum dose, lisinopril, the maximum dose, rosuvastatin, the maximum dose, and aspirin every day. His A1C is 68. It's high with 8.4%. Creatinine of 159 umol per liter, 1.8 milligrams per deciliter, and a GFR of 42, which is in the chronic kidney disease range. But his albumin creatinine ratio is normal. So what would you consider in this patient who already has atherosclerotic cardiovascular disease and chronic kidney disease?
Thank you, Sally. So again, when you look at the case, you have to look at the key points in any case presentation. So this patient, definitely diabetic. You have the CAD, you have the normal ejection fraction, then a GFR 42. So these are the few things, that will direct you where to add next. So GLP-1 receptor agonist, they can have both indication, the renal indication and the cardiovascular indication. So will be best to add a GLP-1 for this patient. A second choice will be, and especially with the obesity, so that will help them to lose some weight. The second choice will be also, SGLT2 inhibitor that, will help with the renal and the cardiac outcome as well. Pio can be used. This patient has a normal, as I said earlier, normal ejection fraction. So if you add the GLP-1 and SGLT2 and still you cannot get the A1C under fine control, pioglitazone can help you. And sulfonylurea also can be the fourth agent to be added after metformin. So again, if you have access to GLP, SGLT2, you should use them. If not, you have to use the other number 3 and number 4 agents here. But always look at, the CAD existence, the bypass, the ejection fraction, and the renal function. So all that will guide you what medication to use. But in the same time, for example, if this patient's GFR was 19, I will definitely not use the metformin. So that's going to be another factor of limiting, what agent you can use. So you don't have to look only to a bad kidney and try to give them medication with renal benefits, but also a bad kidney function, or let's say, low ejection fraction automatically will exclude the use of metformin for these patients. So you have to use the remaining agents. So all these agents will guide you, or the factors will guide you to choose the right agent.
And you can also suggest perhaps if their blood pressure wasn't well controlled, you could maybe choose the SGLT2 before the GLP.
Yes, I mean, that's always, you can get that extra benefit of, I'm sorry, I'm not know why the green light's coming there anyway. So yes, you're right. So you can use always, the SGLT2 inhibitor to give you tiny push with the blood pressure control, but that's not significant. You may need to still add another agent, later on.
Right.
Okay. Case for Sally.
So the next case is similar to the first one, but this patient has an ejection fraction of 35%, 65-year-old with diabetes, hypertension, hyperlipidemia, bypass surgery, on metformin, lisinopril, Rasuva, and aspirin max dose. Same scenario, but now the ejection fraction is low at 35%.
Exactly. So this is, again, similar scenario, but ejection fraction. So that one point, the EF here, automatically will push you away from PIO because you cannot use it, and will push you toward SGLT2 inhibitor and GLP-1 receptor agonist. But at the same time, so if that is expensive, you may need to add insulin for this patient to control the fasting hypoglycemia, and then you can add sulfonylurea if you have to, before adding rapid-acting insulin or prandial insulin. So look at the key point in any case. Any patient who walks to your office, look at what will guide you to use agent A versus what factor will push you away from agent A. And that will make your life better to choose the right medication for your patient.
And then for this patient, because of the ejection fraction, your first choice would be the SGLT2 inhibitor, because the GLP-1s haven't been shown to improve heart failure, morbidity, mortality, but they will help with the ASCVD risk, mortality and morbidity. So these are all things you think about. Okay, so the next case. This is a very different case. It's an 80-year-old woman in a nursing home. She has dementia, hypertension, and multiple strokes with a history of seizure disorder, and she's bedbound and on tube feeds. She's on metformin 1,000 milligrams a day because her GFR is 40. You can't go any higher than that. Her A1C is 84 millimoles per mole. It's very high, 9.8%. Her fasting glucose level is 15 millimoles per liter, and 2 hours after lunch, her postprandial glucose level is 8.3 millimoles per liter, 150 milligrams per deciliter.
Right. So if you remember one of the slides, Sarah said how to choose an agent. But before choosing an agent, you should know or decide what you are trying to achieve here. So this patient is 80 years young, from nursing home with dementia, hypertension, bedbound, she cannot walk much, multiple strokes, seizures, so and tube feed. So obviously you don't, even though tube feed may sound like, the feeding is regular, but if you don't have the tube feed, and especially in nursing home, you may not have regular meal schedule. Anytime you don't have regular meal schedule, you should worry about hypoglycemia, number one. Number two, and bedbound, meaning this patient cannot go shopping, they cannot go
Նշանակում նա չի կարող խանութ գնալ, չէր կարող իրենց սնունդը պատրաստեն, ուստի սնունդը շատ կարևոր է, դա
hypoglycemia. Moreover, you have the seizure disorders, meaning, you don't have to cause any hypoglycemia to give this patient more seizures. So you have to bring your threshold of treatment higher only because of the seizure and try to avoid agents that will cause hypoglycemia. This patient is already on metformin. So A1C is elevated 9.8. So you have to say, okay, what I will treat this patient for. First thing is you're avoiding hypoglycemia. This patient should not have any low blood sugar because that will end up making this patient outcome much worse. Second, you should decide, what target I'm treating for an A1C. You can treat this patient definitely to target hemoglobin A1C of 6.5, but for you to bring this A1C down to 6.5, I guarantee you will cause average 2 hypoglycemic episodes a day. And that will translate most likely to hospitalization by at least once a week, if not more. So avoid hypoglycemia, choose your A1C. A1C 9 is more than enough. You don't have to bring it under 9, only because by improving the A1C to 7.5 or 8, you will not change the outcome of this patient. The patient's already very complicated. Their life expectancy will not be different if you control their sugar to any tighter. So that's why there's no reason to bombard them with medications and to bring the A1C under 9. And the last thing is easy regimen. So easy regimen meaning you have to give them the most effective medication that will get you to your target without any complications, and in this case, hypoglycemia. So that experience plays a role over here, what to prescribe. So I just gave you here 2 numbers for the glucose, which is 270 for fasting or 15 millimole per liter, and 150 after lunch or 8.3 millimole per liter. So why I give you these 2 numbers? Because I'm trying to guide you here what medication to choose. So the first thing when you have a patient like this, you have to decide, okay, is this patient having fasting hyperglycemia or after meal or postprandial hyperglycemia? Because metformin PIO will help your fasting hyperglycemia, for example, but will not help your postprandial hyperglycemia. And at the same time, if you give the glipizide to a patient or regular insulin, for example, to a patient who's having after meal sugar of the 120, you will cause hypoglycemia. So the more data you have, the better you can treat. So the first thing I will do for this patient usually, ask them, get me some glucose readings. So I tell them check the sugar twice a day, before breakfast and either before supper or after dinner. So having like 2 numbers, will guide me what to use for this patient. So I got the data, and this patient is experiencing morning hyperglycemia, 270. And the postprandial hyperglycemia is perfect, 150. Very simple, because the patient has very poor appetite and she's not eating, or the feeding is controlled via tube feed. So what medication I'll give this patient? GLP-1 agonist. I mean, great choice, but again, is it effective? It can be, but it has side effects, expensive, accessibility is a problem. So I may not use that agent only because it may not give me the result I'm looking for. The second agent, SGLT2 inhibitor. This patient is already bedridden. She's not having postprandial hyperglycemia. I don't know about the rate of UTIs in her case because most likely she has a catheter, so you got to be very careful with that. The third agent, DPP-4 inhibitor, which I love for certain patients, but for this patient, I mean, I can use maybe, I cannot, only because the patient is not having postprandial hyperglycemia, may lower your A1C down by 0.5%, 0.6%, weak agent, expensive. I don't like to waste money on it usually. PIO, it may work, because this patient has fasting hyperglycemia, so there is some insulin resistance, obviously. So a tiny dose of 15 milligram, it may be easy. Sulfonylurea, I will not use for this patient. I'm not sure why these green lines are coming on the slides and I'm not touching it. So sulfonylurea, I will definitely not use only because this patient is not having postprandial hyperglycemia. So giving them glipizide or glipiride or glimepiride or glyburide definitely will give you more hypoglycemia and more seizures. And then you have insulin. So insulins, they come with different, as you know, preparation. You have the long-acting, intermediate, rapid, short-acting. So as a specialist, I would give this patient maybe tiny injection of basal insulin once a day. which is easy, can be done by family members. So I may use basal insulin, a small injection, not high dose, just to bring the fasting sugar down, like, in the range of, I would say, 100 to 160, and this patient will definitely have an A1C under 9 without any complication. But again, if you listen to primary care, they may tell you, okay, I will use a DPP-4 inhibitor, which is fine. It's not a bad choice, but based on my experience, based on how I handle my patients, I believe insulin will be a better choice for this patient. There's only one thing I would like to mention here. I mentioned glyburide earlier when I was talking about the sulfonylurea. I hardly ever use glyburide in my practice, and I never write it because it's kind of a habit, because glyburide is one of the longest acting sulfonylurea. So it's very common for elderly patients who have poor renal function on glyburide to experience extended hypoglycemia. Even after stopping the pill, they may have low sugar for 2 or 3 days after. So please do not write any glyburide, and make it a habit to write shorter duration sulfonylurea like glipizide or glimepiride. So try to not write the glyburide at all for any patient if possible. Okay.
So
Next slide, Sally.
the sixth case is a 60-year-old man with a history of type 2 diabetes, BMI of 38, and hypertension, already on lisinopril, metformin, can't tolerate more than 1,000 milligrams daily. You have tried other medications, including empagliflozin. He got a urinary tract infection with hematuria and clots. With alogliptin, he got urticaria. With semaglutide, he got abdominal pain, possibly pancreatitis. Wasn't sure. And he already has venous stasis edema from his obesity. His A1C is high at 75 millimoles per mole, and he has normal renal function. So what would be your next choice? What would be your options here?
Thank you, Sally. So again, what you're trying to achieve for this patient? I mean, I will think loud over here. He's young, 60 years young. That's, you should have an A1C under 6.5. He's obese, BMI is 38, so you have to help him to lose some weight. Unfortunately, he's already on metformin, but he cannot tolerate higher dose of metformin because he's having GI side effects. He cannot be on SGLT2 inhibitors because he had urinary tract infection already multiple times. He cannot be on GLP-1 agonist because he has some GI side effects and possible pancreatitis. So A1C is 9%. You're trying to bring the A1C down by 2.5%. So I'm just going to take a pause here for 5 seconds, let you think which agent you will add before I tell you what I will do. So you have 3 choices. Pioglitazone, sulfonylurea, or insulin. Just think for yourself for 3-4 seconds, what should I do for this patient? Okay, so when they come to me like this, I'm trying to get them down to 2.5% A1C, down to 6.5. So one thing here, if I have the luxury of trying different metformin preparation, as I said earlier, I may try that and try to reintroduce metformin again with different molecule. Hopefully they don't get side effects. That's one thing I may try. The second thing, the semaglutide, it says abdominal pain, possible pancreatitis. So you have to really question that pancreatitis, because if that pancreatitis is not true, you are losing fantastic agent. I'm not talking about semaglutide. I'm talking about GLP-1 receptor agonists in general that will give the patient weight benefit, cardiac benefit, renal benefit, and also, they may have future benefit for addiction like tobacco or alcohol. So you are really losing a good agent if you don't investigate very well. So I will try the metformin if I can. I will investigate about semaglutide or what happened in the past. And if I can use a different GLP-1 agonist with a smaller dose, slower titration. So you don't have to titrate the medication very fast, so you can give them longer time to get used to the medication side effects. That's two things I will always look into them. But the patient is already experiencing edema, I will not give them PIO. Sulfa is a great choice. Bring the A1C down by 0.6, 0.8%. So the A1C will go down from 9% to 8.2%. I mean, is that enough? No. So insulin is the best choice for this patient in most settings because insulin will lower the A1C significantly, especially if this patient is having fasting hyperglycemia. So what I will do if my first two approaches, they don't work, I will add a basal insulin for this patient, teach them how to titrate the insulin. I get, let's say, 350-pound patient or like 140 kilogram patients, they come to me on Lantus or basal insulin 10 units. And for like a year or two, and the A1C is still 9. So that patient, will require about 80 or 90 units of basal insulin. So putting them on 10 units of insulin and just send them home without guide them how to titrate that insulin will be a big problem because pretty much you're just prescribing medication, you're not getting any benefit of it. So you have to teach the patient how to titrate the basal insulin. For a patient like this, so I put them on, let's say, Lantus. I mean, I feel comfortable putting them, if their sugar is 300 in the morning, I tell them go on 25 units. You don't have to be here or don't have to do that. You can start on 10 units if that makes you feel more comfortable. End of the day, remember one thing, you have to feel comfortable when prescribing insulin. That's the biggest fear of primary care. Low sugar, hypoglycemia, this and that, whatever. So you have to be comfortable with the medication. Don't go with 30 units, go with 10 units. But you tell the patient, in 3 days, you check your sugar in the morning. So finger stick glucose is very important. Remember, diabetes is always about data. Patient, you start checking your sugar in the morning in 3-4 days. In the morning, if your sugar is above 100 milligram per deciliter, I mean, how many millimole per liter there will be, Sally? I mean, what's the fasting conversion?
Well, 100 milligram per deciliter.
7, 6. Anyway, so you can convert that yourself. So our target for morning glucose is 100 milligram per deciliter. You tell the patient whatever your target is in your meter unit, millimole per liter, and you tell the patient. I tell my patients, if your sugar is above 100 in the morning, you will dial that insulin pen by extra unit every day. So you go from 10, 11, 12, 13, 14, 25, 35, 40. Once you hit the 100, you stop there. And then I tell them, if your sugar goes, let's say, under the target of 80 for me as a milligram per deciliter, I tell them cut back by 2 units per day. So by doing that, you give the patient the control over the medication, and they don't have fear of low sugar or fear of insulin. Remember one thing, diabetes is always about empowering the patient. The more you talk to them, the more you teach them, the more you educate them about their feet, about their eyes, about their kidneys, their blood pressure, cholesterol, diet, about their medication, what to expect from each medication. So medication A will give you yeast infection. Watch it, call me. Medication B will give you low sugar. Watch it, call me. So the more you empower your patients about the medications and how to control it, they'll have better control over their condition. I mean, I hate to call diabetes a disease because it's not a disease, will go away after a couple of weeks. It's a lifestyle, it's a condition that you will live in it for the rest of your life. So when you adjust the patient to that new lifestyle as a diabetic, they will feel more comfortable and they don't feel like they have a disease will bring them down and kill them in 10, 15 years. So education, education, education about everything.
So just to summarize, so 100 milligrams per deciliter is 5.6 millimoles per mole for glucose.
So yeah, if you tell the patient check the sugar in the morning, if it's more than 5.6 or whatever number you want, choose a target at least. So 5.6 is 100 is good for a patient who's 60, is healthy. But let's say you have a patient who's 80. You will put them on Lantus the same way. You tell them, you don't give them 5.6 target in the morning. You give them target of 7 in the morning. So you be less aggressive or more liberal, with your morning target. And you don't tell them to increase the insulin by 1 unit every day. You tell them increase the insulin by unit every other day. Depend how sensitive the patient is. So the bigger the patient, more insulin they will require. And they're less sensitive, more resistant. So you can up the insulin 2-3 units at a time, nothing going to happen. And the smaller the patient, more sensitive they are and less resistance they are. So for those patients, you don't up it unit every day, you up it unit every second or every third day. Bottom line, whatever makes you feel comfortable. Find your niche, find what will give you the best result, and you can follow that experience and go from there. Remember, diabetes is always about experience. The more diabetics you see, the better you become and the faster you become. Like at our office, we see average 65, 70 diabetics a day. And we do these changes every day. So the more you see, the more familiar you are with the medication, more data you have, better decisions you can make and faster decisions you can make without any side effects.
And the key with
Yes,
insulin,
Sally.
you want to avoid inertia. You want to keep working on it. You don't want to leave them at 10 units and not go. You want to make sure you change their dose and increase it. So for the next case, he's a 68-year-old man.
Sorry for interrupting. This is so interesting. Just wanted to remind that we have only 25 minutes left, and I suggest, in case if it is possible, to leave at least 15 minutes for the Q&A, if that's possible. Thank you so much.
Sally, let me take this case and just brief it very quick. So this is a patient, 68. Look at the couple of things in the slide. BMI 21. That tells you one thing. You don't have insulin resistance. Okay, BMI 21. Diabetic since age of 32, meaning this patient diabetic for almost 34 years. He lost 18 pounds and urinating 6 times at morning, 5 times at night, A1C 9.8. Over here, you just have to think, the next question will be what to add. The minute you see long-term diabetes, unintentional weight loss, symptomatic hyperglycemia, the answer is insulin. Insulin, insulin, insulin. So you have to know when to add the insulin. Those are the key points. This is a skinny patient, lost 18 kilograms without trying, is urinating nonstop, symptomatic hyperglycemia. So you really have to watch for these things. I'm going to jump on this slide very quick. So what is type 1 versus type 2? So BMI of 32 can be either type 1 or type 2. So don't look at the heavy obese patient, call them type 2 without investigating. At the same time, BMI of 19, which is skinny, normal weight, can be type 1, but also can be type 2 who is insulin deficient. Don't go by the DKA. Type 1 and type 2s, they can have DKAs. So type 1 will go in DKA with lower, mild elevation of the sugar, but if you have a severe hypoglycemia in a type 2 diabetic, you may have a DKA. So DKA is not indicative of type 1 or type 2. Unintentional weight loss can be either 1 or type 2. Remember that. So weight loss is significant, can be in a type 2, but also can be in a type 1 or insulin deficient type 2. When you have 5 uncles with diabetes, this is not type 1. This is type 1, possible type 1, possible type 2, but always think about other types of diabetes, maturity, onset of diabetes, or MODY. Patient came to you on insulin. Don't assume they're type 1. Do not assume they're type 1. Learn or ask why they went on insulin. Is it because of financial, side effects, deficiency, long-term diabetes? Again, admitted for DKA, don't assume they're type 1 always. They can be type 1 or they can be type 2. Patient came to me with pancreatic tumor. Pancreas is gone. There's no beta cell function. That's not a type 2. That's not a type 1. That's a surgical diabetes or diabetes acting like type 1. You treat them like type 1. Doesn't matter what their body weight. They have no insulin. So they are type 1 pretty much. That's how you treat them. We're going to move. Okay. I think we're going to pass this one. The slides are available for you guys, or you can review it later on. But just remember, the difference between different types of insulin. each patient has the right insulin to start with. So do not assume, all insulins are the same. One thing I can give you here, this is very helpful. If you use mixed insulin, always use it before the meal, not at bedtime. But if you can divide the premixed insulin over 3 times a day before meals, instead of having it twice a day only, that is associated with less hypoglycemia and less weight gain. So just be aware of that, okay? Okay, this you can review by yourself. This is very important here, the technique of injecting insulin. Patients, for whatever reason, they may not change their needle frequently, and so the left upper corner picture is a fresh needle. The bottom corner, right corner needle is a needle used 6 times. These are microscopic, electronic microscopic pictures, by the way. So always talk to the patient about the technique of insulin. It's very important. Review the slide, and any patient comes to you with sugar of 300, and they tell you we just injected 80 units of insulin, they're either lying or they had 500 grams of carb for their meal and bottle of juice, or they're not injecting their insulin, or they're injecting it wrong. So always go over the technique. Make sure they're injecting their medication right. It's a very common mistake, especially when you see a skinny patient, elderly patient is taking 15 units before each meal. Sugar is very high. Most likely that patient is injecting the insulin wrong. So hypoglycemia is very important to educate the patient. One thing, you have to remember, hypoglycemia unawareness or severe hypoglycemia is when the patient requires assistance from another party to treat their sugar. For example, an ambulance, EMT, physician, wife, husband, boyfriend, girlfriend, whatever. Another person gives them the glass of juice because they were too weak to walk to the fridge to get the juice. So that's called severe hypoglycemia. Educate the patient. But hypoglycemia unawareness is the condition when the patient is having multiple hypoglycemic episodes, and their threshold for generating symptoms becomes too low. So then, that will be a big problem for them. So the first thing you have to do is not to tell them eat more, not to tell them to do anything. The first thing to do is to cut your medication and bring the sugar up so the patient threshold for hypoglycemia readjust, and they can have the symptoms with appropriate drop in their sugar. We're going to skip case 8, I guess, Sally. And this is a CGM picture, by the way. You see here the red, how often the patient is getting hypoglycemia. So the treatment here is not to tell them to eat more. The treatment here is to cut the insulin to make them, have better readings. Sally, should we take questions?
Yep, we can do the questions now. So this is just some important points. We just wanted to make sure we emphasize that screening and prevention are imperative. You must address diabetes early, diagnose them early so that we can prevent progression to retinopathy and neuropathy, and help with their reduce their risk for cardiovascular and chronic kidney disease. We know that this all increases their poor quality of life and increases costs to the medical system. And the most important challenge is the lifestyle change. In primary care, this is the most difficult challenge. So we've had many, many, many questions. We have questions from before, we have questions from now. We tried to answer a lot of them during the talk, but some of the questions that came up were about pregnancy diabetes.
Okay. Oh, you want to take it or should I take it?
No, you could take that. That's a specialist question.
Yeah. Good. Okay. So I don't know how the screening process for ladies, in a pregnancy for hyperglycemia in Armenia, but over here, patients, they're screened always for hyperglycemia at week 27 with 1 hour glucose tolerance test. If they fail the 1 hour glucose tolerance test, then they will get the 3 hour glucose tolerance test. And after that, if they fail the 3 hour glucose tolerance test, they end up seeing, most likely endocrinologist, or if the OB feels comfortable doing it. But the first thing to do is eating right, the snacking, the the carb content, checking the sugar. And most patients, they do very well usually with just eating better. But the one thing you have to worry about, those ladies, they will have a risk of diabetes by 20% after the first pregnancy compared with gestational diabetes. So you have to screen them after that and screen them for the future pregnancies. And every pregnancy will add 20% risk of having diabetes again. So it's very important to go over the screening and educate them and make sure they lose the weight after pregnancy. That is the biggest problem, because if they lose the weight, the risk is 20%. If they cannot lose the weight, the risk of developing diabetes post-pregnancy is much higher. So always help them to lose weight post-pregnancy.
And there were questions about treating diabetes during pregnancy. And I think the only thing really that's safest is insulin, correct, Dr. Prasad?
Insulin is the safest, most robust agent that we use. We don't recommend metformin because metformin, especially in the first trimester, will affect the fetus size. But let's say you have a pregnant lady who's on 400 units of insulin a day and the baby is already large, I would use metformin just to improve the insulin sensitivity. But insulin is the best agent, best choice, for pregnant patients. Yes.
And then the other question was the first agent to use in diabetics with hypertension, like we discussed earlier, the ACE or the ARB, if
Yes.
they have proteinuria or chronic kidney disease, and hypertension. But if they don't, then you can use any of the agents, calcium channel blocker, diuretics. There are some questions. They say that GLP-1 is not available in Armenia except in the black market. So unfortunately.
Actually, Sally, I just want to address two questions came in the chat. Actually, I saw them, they're not here. So the first question is, hemoglobin A1C, even though it's the gold standard to diagnose diabetes or to monitor diabetes care or progression, but usually at later ages, post 70, your hemoglobin A1C may not be too accurate. The accuracy of the hemoglobin A1C will be down. So you may have a A1C of 6-7%, but the patient's reporting glucose in the higher range that A1C of 9. So don't depend only on the A1C for elderly patients. Always check the finger stick to see what you're treating. Number one. Number two, if you have any blood disorders that your A1C, because it's attached to the red blood cell, to hemoglobin, and there's hemoglobinopathy, at that time, your A1C may not be accurate. So don't depend on A1C in patient that has thalassemia, for example, or severe anemia or polycythemia vera, because that A1C is not accurate. At that time, you can order fructosamine. That was a question mentioned. So fructosamine is a good test that does not depend on your hemoglobin level, and usually it reflects the last 2 weeks of glucose control. It's not done fasting. You don't have to fast for it. So it's a different marker than A1C, but it's very accurate marker to monitor the glucose control for a patient who cannot use A1C as a standard.
Some of the other questions. Go ahead.
I was wondering, should we also try to cover questions that raised up in the chat during the event, or
we captured most of them, Asrig,
Yes.
But what do you have? You can always add. Give us some.
Okay, I'm not sure if this was covered. There is a question asking, do you discuss the bariatric surgery possibilities and efficacy with patients in primary care practice? And when do you suggest bariatric surgery for type 2 diabetes? Let me quickly translate to Armenian and hear your response. Արդյոք դուք քննարկում եք բարիատրիկ վիրաբուժության հնարավորությունը եւ արդյունավետությունը այցելուների հետ առաջնային օղակում եւ երբ եք դուք առաջարկում բարիատրիկ վիրաբուժություն տիպ 2 շաքարային դիաբետով այցելուներին?
Sally, you take that?
Okay, so
I can take it. Whatever you want.
it's okay. The guidelines varied different locations. Usually if their BMI is over 35 and they have diabetes, then that is an indication for bariatric surgery. But we usually try to do everything else first, try to lower their weight with lifestyle and medication first before we go to that, unless it's very severe, BMI maybe over 40, because that too, it's a lifestyle change. Patients who have bariatric surgery, if they don't comply with a small a better diet, right? Like Dr. Fazekian said, then they're going to gain the weight back again. So they have to be psychologically prepared to do the lifestyle change.
One thing I will add here, bariatric surgery is a fantastic procedure. On the long run, is much better than GLP-1 receptor agonists. So, first of all, you have to believe in the procedure to be able to recommend it to the right patient. I'm going to use brand name Ozempic is not bariatric surgery. Please do not tell a patient that you can lose the same amount of weight if you go on GLP-1 agonist versus surgery. Surgery always better. On the long term, it's cheaper, gives you more benefits, makes you live longer. GLP-1, they don't have the benefits like that yet, number one. Number two, if you have a patient who qualify for bariatric surgery, and they've been diabetic only for 10 years. So if you do the gastric surgery and you make them lose the weight, there's a big chance they will come off of their diabetic medications, 100%. But, I mean, would I stop the GLP-1? No, I'll keep the GLP-1 on board. But if they're on insulin, if they're metformin, they can come off the drug. The idea is, that weight loss will reverse insulin resistance to a level that you can come off the insulin, the diabetic agents, and try to survive with the remaining beta cell function. So that's very important factor. So gastric bypass, always good for type 2 diabetes, yes. I mean, unless they don't have the weight problem.
Thank you.
Any other questions you have?
Yes. Yes, if I may. There is a question related to gut microbiota. In particular, is there any evidence that changes in gut microbiota influence the onset or progression of type 2 diabetes? So is it advisable to prescribe probiotics? Let me quickly translate. Արդյոք կա գիտական տվյալներ, որ մեր աղիքների, մարդկանց աղիքների միկրոֆլորայի փոփոխությունները ազդում են շաքարային տիպ 2 շաքարային դիաբետի սկզբի եւ առաջընթացի վրա եւ արդյոք խորհուրդ է տրվում օգտագործել պրոբիոտիկներ.
Probiotics, they have no role in diabetes management, but that's a big question, the microbiome, the effect on your body in general. In a clinical setting, does it make a difference? No, definitely. So, I mean, don't tell a patient your diabetes will go away if you take probiotic, so use good medication, effective medication. Again, I'm sure there is some study will show you, that the progression will change based on your flora, but would I say that to a patient? No, because there's nothing saying that using probiotic will change your risk of micro complications or microvascular complications. One thing I like to make comment, there was a question about diabetic retinopathy. So, I mean, you can definitely ask ophthalmologists for the classification of diabetic retinopathy. That's beyond our scope for this talk. But you have to remember one thing. All diabetic microvascular complications are reversible. So when a patient comes to you with A1C of 10, sugar of 400, telling you I'm having burning sensation of my feet, diabetic neuropathy, you don't give them neuropathy medication, you fix their sugar, their diabetes, neuropathy will get better. Retinopathy will get better. That's why, for example, when we do urine protein for diabetic nephropathy, we don't treat from the first time. We tell them, okay, let's fix the sugar, let's repeat the test one more time in 6 months, because you have a big chance of improving or reversing that microvascular, not macro. I'm not talking about heart, brain, please. I'm talking about kidney, eyes, nerves. That you will reverse the complication if you control the diabetes. But macrovascular complications, CAD, CVA, stroke, heart attack, that is from controlling the blood pressure, cholesterol, diabetes as early as possible. We have a very famous study that we go by until now from the VA department, from the Veteran Affairs, that when you control diabetes soon, the risk of diabetes macrovascular complication goes down significantly. Will not go down to non-diabetic patient, but will go down significantly. So just look for pre-diabetes. You are primary care, so your job is to look for pre-diabetes, not diabetes. If you don't diagnose the pre-diabetes, you find someone is diabetic, meaning you missed something important in your practice. You did not see that coming. And I believe as a primary care, your job is to catch the pre-diabetes before it goes to diabetes. If you do that to your patient, you can bring the rate of diabetes down significantly in Armenia.
Okay, thank you very much. There was also a question related to usefulness of intermittent fasting. Ինտերվալային սովի օգտագործումը. Is there any evidence in case of diabetes type 2?
You do that, I take it.
You take it.
So intermittent fasting is a fantastic thing to do. I mean, but again, remember one thing, what you said earlier, like, for example, I always bring myself example to my patients. My mom never fed me breakfast because she never had breakfast. So I did intermittent fasting my whole life. I'm used to it, but someone who eats 3 meals a day, you go tell them, don't eat breakfast. That is challenging. You cannot. So you don't have to tell the patient something they cannot do, please. Like exchanging, a meal for salad. Those are like extreme behavior that does not work. So if you can do intermittent fasting, it's great because it gives you weight loss. Weight loss gives you insulin sensitivity, will help the sugar directly. But would I recommend intermittent fasting as a diet to my patient that have diabetes? No. Would I tell them go on Atkins? No. Would I tell them go on Mediterranean? No. You have to teach them about food, educate them about carbohydrate. Some patients, they tell you, oh, you know what, I'm not having sugar, but I'm having cake. I'm having healthy fruit. That's completely wrong. Because if you eat 4 or 5 apples a day, which is perfectly fine, healthy food, but you know what? Your sugar's going to go sky high if you're diabetic. So educate your patients about the food they're eating and teach them how to control the total carb and calories in their diet, not, to change their lifestyle. For example, like intermittent fasting problem, the other thing, people, they do it wrong most of the time. At least I see in my practice. They come to me, they gain weight on intermittent fasting. You know why? Because they decided to eat breakfast, lunch, and dinner and a couple of snacks in 2 hours. So that's wrong. That's not intermittent fasting. So the way you do intermittent fasting, you tell your patients, go monitor your diet. You give them tools to how to count carbs and calories, and they come up with average daily carb and calories. Then you tell them, cut back that total carb and calorie by 30%. Don't eat the first 4 hours of the day and don't eat the last 4 hours of the day. You're going to make it tougher, do 5 and 5, 6 and 6, whatever you want, but at least 4 and 4. And then you tell them, cut back the food content by 30%, and your diet is fine. You eat big lunch, you eat small dinners. In the US, we do small lunch, big dinner. So for you, it's very good. And then you eat that reduced total number of calories and carbs, 60% beginning of the period and 40% toward middle to the end of the period. And then that is a good intermittent fasting. So, but is it recommended diet for diabetics? No. You tell me, is it any better than Atkins or European diet? I'll say no. Any diet can be bad, any diet can be good. You just have to teach the patient to do whatever makes them happy and with reasonable target, and they can do it for the rest of their life. The change in the diet should be consistent. They can do it for the next 20, 30, 40 years, not only for 6 months, to fit in the dress for a wedding or to be summer season, whatever it is.
Okay, thank you. Moving on with, yes? Okay, moving on with pregnant women as patients. Just there was one comment for your information that there is already screening available for A1C in Armenia. It's routinely done in pregnant women, and there was like additional question related to gestational diabetes, which is the following. Let me read in Armenian, then translate. Ասեք գեստացիոն դիաբետի ներկայում ընդունված ախտորոշման նորմաները տոլերանտային տեստից 1 ժամ եւ 2 ժամ անց. So the translation will be, please tell the norms of gestational diabetes diagnosis tolerance test after 1 hour and 2 hours, if I could translate.
Can you say it very quick?
So could you please tell the international norms of diagnosing gestational diabetes 1 hour and 2 hours after tolerance test?
I mean, let me repeat the question if I get it right. You want me to give you the level of the glucose?
I suppose. Maybe I myself do not understand the question. I'm
Is it in the
sorry.
chat? Hasmi, is it in the
Yes.
chat?
Yes.
Okay, let me open the chat. Hold on 1 second.
So
Çin Artuner.
yeah, let me quickly copy and paste it in the chat so that you see.
Hadi. Okay, Gasek. Hold on. Gasek. War magnet.
That one, Gasek gestation diabetes.
Okay.
Maybe they're asking about criteria of diagnosis of
Criteria,
gestational diabetes.
there's different criteria. I mean, the numbers are in millimole. They're not in millimole. I'm not going to confuse you, So, but if you just go to the ADA website, or Google ADA, and or actually it's the Obstetric Association of the U.S., not the ADA. You can have the targets, So you have 4 levels of the sugar: fasting, 1, 2, 3 hours. Okay, this is the confirming after the 1 hour tolerance test. So 1, 2, 3, 4. I mean, fasting 1, 2, 3 hours. Any 2 numbers abnormal of the 4 that will classify as gestational diabetes or diabetic. I'm sorry.
Okay, thank you. I think we're moving to the end. There were other questions, but those were already addressed as far as I could understand. For example, related to our approaches in case of anemia or usage of Ozempic in case of diabetes type 2, etc. Those were already addressed. Anything else to add, dear speakers, related to the raised questions?
Sally, what do you want to add anything?
I think we addressed most of them. I think during the talk, there was a question about patients with type 2 diabetes breastfeeding, and I think that's okay.
Can I address that very quick? So, you cannot use, we don't recommend using a GLP-1 receptor agonist when you're breastfeeding, just for the fear of the medication or the preservative in the medication to go to the fetus. So we don't recommend GLP-1 receptor agonist for breastfeeding. And you should be off the medication 3 months before you become pregnant. You cannot be on it while you're pregnant, and you cannot be on SGLT2 inhibitors when you are pregnant, by the way.
Mostly
Very
insulin.
important. Thank you.
And
Thank you.
I just like to, okay, Sally, I'll go after you. I have one more point to add before I forget.
Go ahead.
Okay, one thing, like we discussed GLP-1 receptor agonist and thyroid cancer. It is not thyroid cancer. It is medullary thyroid carcinoma, a specific type of thyroid cancer. So not every thyroid cancer patient cannot be on the medication. Only if you have medullary thyroid carcinoma. Thyroid nodules are fine. I get this all the time. They come to me, or they didn't give it to me because I have a thyroid nodule. No. If you have a thyroid nodule, you have a biopsy, there is no cancer, there is no medullary thyroid carcinoma, there's no family history of MEN2, you are fine. You can be on medication.
Okay. I guess this is it. It's 8 p.m. in Armenia and 11 a.m. in the US in Eastern Standard Time. Thank you very much, dear participants, for joining. I think we have never had in recent years such a big number of participants. So I am really glad it went smoothly. There were a couple of issues with noise, but we removed them. Thank you very much, dear speakers, AAMA representatives, for this opportunity, and we will be in touch.
Thank you very much. Thank you for having us. Thank you
for your time and attention.
Thank you very much.
Thank you.
Thank you
Bye.
very much.
Thank you very much.